this stage. The intention was that the next time we spoke, we would speak specifically about methamphetamine. But we're also going to change to a Zoom platform because it's quite difficult to operate out of this particular platform. So, for example, I can't actually see what's on the screen at the moment. And I'm presuming that you've got a picture of a house with some balloons attached to it. Is that correct? If anybody could just answer.
That's correct, Sean.
Thank you very much. Okay, so what we're going to talk today about is stimulants. And this is a primer or an introduction to stimulants, just to give some general ideas and to talk about it a little bit. And then the next session, we would talk specifically about methamphetamine, which is an emerging problem in the Tshwane setting at the moment. So when we talk about stimulants, we aren't just talking about illegal stimulants or drugs that are deemed to be illegal. Most of us know coffee as a stimulant, and we know that there are potentially problems with coffee, cardiac events in particular. If you drink too much coffee in the morning, you can feel quite jittery. We know that we have withdrawal symptoms from coffee as well. If you stop taking it for a while, you tend to get a headache. You feel flat, you come down. And alternatively, if you haven't taken coffee for a long time and you take coffee, it can have significant stimulant effects on you. An example of this is I hadn't drunk coffee at all for about a year and a half. And for various reasons, I had a double espresso, which was not the wisest idea. And it honestly felt like a very powerful stimulant drug. We build a tolerance for stimulants quite quickly, and coffee is one which most people are familiar with. In the past, we've also had things like coca tea, which we can still get in certain areas, and in fact, it's fairly effective in the treatment of people who've got cocaine use disorders, and even endorsed by the Pope. We've had wines and sort of wine-type products like ports and that, which have been infused with cocaine during the history, which is obviously the cocaine is a stimulant. Most of us know that cigarettes are stimulants as well. Nicotine is a stimulant, should I say? And once again, you get withdrawal symptoms when you come off it. So these are some of the stimulants that we've seen historically and we see in day-to-day use. But of course, there are also pharmaceutical stimulants as well that we get quite a lot of. And stimulants were one of the highest prescribed classes of drugs in the United States in previous years. And in particular, we're talking about things like Adderall, which we don't get in South Africa, but we get over there, which is an amphetamine, very close to methamphetamine. We get methylphenidate, which is a stimulant, which is used for the treatment of ADHD in children and in adults. And that is a stimulant, or Ritalin, as some people may know, and is pretty common and prescribed widely. You also get in other settings lisdexamfetamine, which is a prodrug, which turns into an amphetamine in your body. You get dexamphetamine, which is an amphetamine as well. And we know about the drugs from the 50s, and that the benzodrines and the dexedrines, which were used commonly by truckers and late night workers and shift workers, which are stimulants as well. So we've got a lot of these pharmaceutical stimulants. And one of the pharmaceutical stimulants, which we don't realize often is a pharmaceutical stimulant, is cocaine. It's used for eye surgery and for as an anesthetic or local anesthetic in certain cases as well. And so this is cocaine from an unregulated market, from the unregulated markets. These photos are from a recent study we've been doing into drug sellers in South Africa. And this cocaine, they hold bricks of cocaine there, but cocaine comes in two main forms in South Africa. One would be the powder cocaine, which people snort. It's fairly expensive for good quality powder cocaine. It's very easily contaminated. And we've got freebase or crack cocaine. Crack cocaine was very common in Tshwane, and it's losing popularity at the moment because of its price and because of the competitions that there are. And we've also got the crack cocaine. The one thing about crack cocaine is that it tends to have one effect, one major effect with people, and that is to make them want more crack cocaine. So you've got this cycle of rapid binging, stopping, and then using again, and going out to purchase more, and this constant need for money to buy the crack cocaine. We saw crack cocaine use commonly with people who are using heroin or IOP up in Tshwane. And this is a typical pattern around the world. You'll see opioids mixed with stimulants like cocaine. In the United States, speedballing is common, which is the mixture of cocaine and heroin as well. More recently, of course, in Tshwane, we've seen methamphetamine. These are some photos of bulk quantity of methamphetamine. The methamphetamine, interestingly enough, in South Africa has been here since the 1990s, or before that actually, but in sort of fairly large amounts in the 1990s, mainly in the Western Cape. We know that methamphetamine has been common down here. It's the drug that I first came into contact with in a treatment setting in Lavender Hill. The gangs were using it. And there are reasons why they'll use it, which we'll talk a little bit about in a second. I'm just going to stop sharing for the moment before we get on to the next topic. But anyway, so we know that stimulants are stimulants. They make people go up. They make you feel better about yourself. They make you feel confident. They make you feel energetic. And the typical signs we get of stimulant use would be you'd get dilated pupils in the person. That's something which you can see quite common, which is the exact opposite of people who use heroin, which you get the pinprick pupils. In stimulant use, you get the wide open pupils. They're trying to take everything in. You've got a lot of energy, and most stimulants work on the dopamine system. And dopamine is not about liking. It's not necessarily about pleasure either. It's about wanting. It's about motivation. So people, when they use stimulants, feel motivated. Of course, when you don't have too much to do and you're feeling motivated, you end up often in rapidly repeating cycles of behaviors. There's a common joke in Cape Town amongst people who use stimulants that you can fix things broken, because you're just ruminating and you're fixing and you're going around in circles. You pack your sock drawer 100 times and you've got this sort of almost obsessive kind of compulsive behavior with the use of stimulants in certain circumstances. Of course, the pharmaceutical use of stimulants is quite different, and we see that in people with ADHD, you get a lot more concentration for those people, a lot less distractions. They're able to focus more. They're able to perform better on the recommended doses of the recommended drugs when they've got severe symptoms of ADHD. I can speak personally to that issue. I was on methylphenidate from fairly young. Some people might say that explains some of my behaviors in my adult life, but we know the data is fairly good for young people who've got ADHD. If behavioral interventions and contextual interventions don't work, which should always be your first line, we know that some people will benefit tremendously from methylphenidate or other stimulants in the United States, Adderall and that kind of thing. The problem comes when you cycle people in and out of these medications. They tend to then seek them out during periods when they don't have them. So that's pharmaceutical drugs. The other signs that we see of people using stimulants is we can see them sweat. They can become dehydrated. They can become frenetic, and you can also get states of paranoia and moving into psychosis as well. We'll talk a little bit more about that later, but it's in particular these kinds of things and the psychosis that leads a lot of people to have this concept of the demon drug. And as you see here, we're not only talking about South Africa with this problem, around the world. This demon of methamphetamine is coming up in Australia. It's called ice. In the United States, it's the most evil drug on earth, apparently. And the media really hype these things. And we're going to go into a little bit about why this is not particularly helpful. So we've got the demon drug. We've also got don't feed your drugs to the crocodiles, which is a kind of ridiculous concept. So what happened in this particular instance in this news report, the police were raiding somebody's house and they caught them flushing methamphetamine down the toilets. And so this news article came out and the warning, don't flush your methamphetamine down the toilets because otherwise you're going to get these crazy alligators that are going to eat people. Of course, you've also got these very strong campaigns like this, leaving a friend for dead isn't normal, but on meth it is. There were other ones which said, she used to be my daughter, but now she's a prostitute. Don't even try it once, methamphetamine. There are ones that it's not normal to rob an old man and hit him over the head, but on methamphetamine it is. Of course, these are very stigmatizing messages, and these public service campaigns often do a lot more harm. And often they come back to bite people. So here's one which was probably not well thought out in the United States. I find it quite amusing that that we see these kinds of messages. I'm not sure what they meant by this. Maybe they mean everybody's on meth, or maybe they mean they're onto the problem of meth. In South Africa, we saw very similar campaigns with in the Western Cape. I don't do drugs, but and in fact, most of the people who were featured in those do some sort of drugs or not. So these public service announcements often lead to these very exaggerated stories, which is a problem because it creates a self-fulfilling prophecy often. So what we need to really do is look at what the science says, and that's what we're going to try and do not only today but over the next session as well. So please, what I would like you to do as well is, if you've got any questions, to pose them in the chat. At this stage, Dee, if you could interrupt me if you've got any questions that you'd like to raise, because I'm not quite sure where my chat box is. I'm not seeing it at the moment, but we'll get to that. So what we're going to talk about now is a little bit about what's happening when we see the science compared to what the anecdotes that we hear compared to what the media are saying. So there seems to often be a disjoint between these things, especially when it comes to stimulants. So at the moment, we've heard that apparently stimulants in the city of Tshwane are 10 times more addictive than niobe, which is something that I definitely saw recently. Now, the fact of the matter is, stimulants do not have the same kind of dependence that heroin or niobe would have. Heroin or niobe, if you stop taking it, you actually get pretty sick. You need something to manage that. You feel like you've got really bad flu, stomach flu, and it feels like you can't go on. You feel almost as though you're going to die. When we talk about stimulants withdrawal, we're not talking about the same level of withdrawal. There's not the same level of physical dependence, but there is certainly a level of psychological dependence and a level of how can I put it, a level of anhedonia, of feeling down. You're not feeling up exactly. So as we know, what goes up must come down, and people who use stimulants must come down at some stage. One of the stimulants I haven't mentioned is MDMA, which obviously acts on serotonin as well as the dopamine levels. And there's the thing called Suicide Tuesdays for people who, after they've been partying on the weekend and they've taken a lot of the MDMA, they come down on a Tuesday, their body's depleted of the 5-HTP in their systems, their dopamine levels are down, their serotonin levels are down, and they're feeling really bad about themselves. That's not a physical dependence in the same way that heroin would lead to a physical dependence, but it is a dependence, and often it needs some way of management as well. There was a very interesting study that was done in the UK on what the best antidote was for that. And believe it or not, the result of the study, which was, I must just check where it was published. It was initially done as a kind of a joke, but they then were planning on formalizing it, and I must just check whether that's been done. But the results of the study were that the best cure for come down from MDMA was to play with puppies on a Tuesday. And I think that although that's quite funny when you think about it on one level, on another level, it's important to note that things like playing with puppies or being integrated into a community or having friends to be with does stimulate dopamine levels in people. We are motivated by positive affirmations and positive experiences. And this is really important to note when we're talking about interventions for most substance use, but in particular for stimulants, because with stimulants, we don't have a lot of pharmacological interventions. We don't have a replacement therapy like we have with people who heroin dependent, where you've got a methadone or overseas diamorphine. We do know that, however, that if you took people off their ADHD medications, they would probably go towards street drugs. And then that suddenly you would find that things like methamphetamine would be treated with things like methylphenidate, because people who have got ADHD would gravitate towards stimulant drugs to try and self-medicate those things. But not everybody who uses stimulant drugs has ADHD, but it's something we should certainly consider when we look at somebody who presents with a stimulant use disorder or dependence on stimulants. So we've got to find a new way of treating this, because the majority of people are not going to respond well to there's nothing to give them, actually. There's no medication to give them. So we've got to find other ways of doing that. And one of the ways is positive affirmations and by triggering dopamine through other means within people as well. So the question is that I was asking is, what is the disjoint between the science and what we're seeing on the street? And one of the major differences is dose. We don't know the level of dose that people are taking on the street. We know that when you're taking pharmaceutical stimulants or when you're taking a cup of coffee, you know roughly how much caffeine you're getting in the coffee, you know how much nicotine you're getting in the cigarette, but you have no idea how much methamphetamine you're getting when you smoke it in a pipe. You don't know how much you're getting when you inject it even, because you've got some adulterants in it. We're going to go into that more the next time that I speak to you about methamphetamine, but we don't really know what dose a person is taking. We start seeing problems when you've got a combination of drug mixing. So if you're mixing your stimulants with alcohol and with cannabis in particular, you're increasing your rates or your chances of developing some negative effects from the drugs. We also need to know that the context in which a person's taking it also makes a difference, and where they're getting it from makes a difference. Psychologically, their drug expectancy. And this is why it's very important not to perpetuate the myths that there are out there. I can give you an example. A little while ago, there was this rumor that there was flakka or alpha PVP in South Africa, but there wasn't actually. It was methamphetamine that was just breaking into some of the markets in Tshwane. And that I know because it was drug tested. We actually took those samples to the police lab. Jacob Westraat did that and had a look at it. And we know that there was no alpha PVP in South Africa. They didn't find any. The police certainly didn't find any. But people were saying, oh, I've taken this flakka, and they were suddenly presenting in emergency rooms with extreme outcomes. And those outcomes really needed to be managed by symptomatically treating the individual, but also by giving them the messaging that you're okay. You haven't actually taken alpha PVP, you've taken a stimulant, and this is a perfectly normal reaction to the stimulant, to get high blood pressure, to have a tachycardia, to feel a little bit anxious perhaps when you're taking too much. And this is a response from your body because you're taking too much, and then the psychological effects of believing that you're on some sort of zombie drug or some drug that's going to cause you huge amounts of harm, that exacerbates the situation. So I think here we have our first lesson, which is basically when you're dealing with drugs, whatever drug it is, Let's stick with the science and manage the expectations of the individual, because otherwise we're going to get self-fulfilling prophecies and people are going to react far worse to the drugs. Also, if we look at a lot of the drugs at the moment that are coming out with the move of methamphetamine into Tshwane, a lot of those videos, if you go back, are actually videos from a long time ago with totally different things. And we got the same with Flucker. There were photos in Cape Town of people jumping off buildings and that, but when you really got into it, these were suicides that had happened over previous years. They were not the result of the Flucker at all. And so when we're looking at stimulants, in particular, and the development of psychosis, we've got to look at a couple of other things as well. What was the person like beforehand? Did they have a predisposition towards psychosis? And has the stimulant exacerbated that or brought about something which may have been lurking in the background but wasn't significant and is now made significant by the stimulant? Or are we talking about stimulant-induced psychosis, which is largely dose-respondent? And we know that stimulant-induced psychosis usually resolves within 72 hours in most cases. So if it's resolving within about 72 hours, it is likely to be the stimulant-induced psychosis. But remember that each time a person goes into a psychotic episode, it becomes easier for them to go into a psychotic episode again in the future. And so it isn't non-problematic. It is still problematic, but if you can catch it early enough and if you can manage people's expectations and talk to them when they're not floridly psychotic about the drug effect and about the dose response, we start seeing a lot less people become psychotic or suffering from the conditions that we so often see. What are stimulants going to give people at right doses? All stimulants are going to increase energy at small doses or the correct doses. They're going to, for some people, increase focus. For most people, they will increase motivation. They will also make people feel better about themselves, which is why a lot of people take them. They will also, at times, lower inhibitions, but at the right dose, in some studies, they've seen they've actually increased self-control in some people. So it's not a foregone conclusion that people's inhibitions just totally disappear at the right dose. And I cannot stress more than enough, you've got to be talking to people about dose response. The next thing that really heavily impacts upon people who use stimulants is sleep. We know that if you really want to get psychotic, all you do is you stay awake for more than 48 hours. Most people will start experiencing oral hallucinations, hearing their names called. They'll start seeing visual hallucinations, and they will start, after a bit more time, start developing delusions as well. I'm sorry about that ringing. I don't know why that is. My phone is supposed to be on do not disturb. So anyway, apologies for that. So what we will see is people who don't sleep will start developing delusions, and they will eventually go into a floridly psychotic state. There's a terrible disease called terminal hereditary insomnia, where people don't sleep basically for about 18 months and then die. But there's no cure for it. There are very few people who've got the gene for it, but it is out there. And we know from sleep deprivation experiments and torture experiments by the military that people who don't sleep become floridly psychotic, and this is one of the key things that contributes to psychosis. So far we've got three things that contribute to it. We've got the dose response, we've got the mixing of drugs, and we've got the lack of sleep. The lack of sleep, people can overcome a lot of the negative effects of that just by resting for some time within every 24-hour cycle. There's a joke amongst methamphetamine users in the Western Cape, which is the best thing about taking methamphetamine is it's only 2 more sleeps until Christmas. And that is what it seems like often. You know, people who are on stimulants often live their life in 72-hour cycles, and so you get this up and down binging kind of behavior. One more point before I turn to you all to see if there are any questions on that is to say that when somebody presents in front of their psychiatrist or their doctor, and they say, you know, I've got ADHD and I've been prescribed Ritalin, and what I do with my Ritalin is I save it up until the last weekend of the month, and then I pop it all and I go partying for 2 days. Most psychiatrists and in fact, most of the score mechanisms, sorry, not most psychiatrists will know what's going on there. But most of the scoring, like if you were scoring the person on an assist score, they would come up as low to medium risk, right? Sorry, what am I saying? They would come up as high risk because they binge using the drugs. The psychiatrist would say to them that you're abusing the drugs. You shouldn't be using them like that. How you should be using them is by using them in small amounts on a daily basis within the dose response. Sorry, I messed that up totally, my story there. To reiterate, if you go to your psychiatrist and you tell him that you're saving your methylphenidate or your Ritalin till the last weekend of the month so you can have a great party, and you party it up, he will tell you you're abusing the drug, right? However, if you do an assist score with somebody and they are using methamphetamine once a month, that would come up as a low to moderate risk score, right? And if somebody methamphetamine every single day, that would come up as a high risk score. But that shows us there's a great disparity about the way we think about the drugs and medications people take. Because maybe that person is taking on a daily basis a very small amount of the methamphetamine because they're self-medicating for ADHD or narcolepsy perhaps, or something else. Or maybe it just makes them feel good and better able to function and focus, right? However, that is seen by most people in the drug field as a major problem, whereas binging occasionally is not. But when it comes to pharmaceutical medications, it's exactly the opposite. So we've got to be careful how we frame these things, and we've got to really examine what are the impacts on that particular individual's life. Stimulants can be very good for some people. They can be awful for other people. We should always be trying to encourage people to look towards regulated rather than unregulated stimulants. The take-home message today is this. If people are taking stimulants, they're probably doing it for a reason. We can help resolve stimulant use disorders by giving people meaning and purpose in life and encouraging them to engage in activities which will stimulate their dopamine and sense of purpose and meaning. It will encourage relationships to develop deeper relationships. Beyond that, there's not much medication we can give. However, we should be checking people for ADHD, because often prescribing ADHD medication to somebody who's got it will reduce or stop the use of unregulated street drugs. If people feel they can't stop using stimulants, you've got to talk to them about what they're doing at the same time. Are they taking cannabis and stimulants, or drinking a lot of alcohol and stimulants at the same time? By the way, for cocaine, that's particularly dangerous because it forms a new compound in your body, which can cause a lot of cardiac problems. So don't drug mix, get sleep, eat when you can, stay hydrated, but not too hydrated. And the most important thing about it is moderate your dose all the time. That is the key message that I've got, but I see Pam has got a question. So Pam, do you want to ask your question?
Morning, everyone, and thank you for this information, Sean. I wanted to find out, you said something about screening for ADHD. Is
Yes.
that something that is only done like at a clinical, like at a hospital or so, or are there screening tools like the Assist where we can sort of screen and then refer?
Okay, so the problem with ADHD is it's very difficult to screen for. So in an ideal world, and listen, this is a dream in our setting. What you're supposed to do is you're supposed to get collateral information from parents, the school. It's got to be present over a period of time, and you've got to have a psychiatric evaluation. That's not going to happen in most cases in South Africa. And also you get different degrees of ADHD as well, and sometimes you just get naughtiness or distraction, which is perfectly normal. You know, you don't want to assume that everybody's got ADHD. In younger people, one of the surefire ways to test whether somebody's got ADHD is once you've got some of the symptoms present, or you can actually prescribe low doses of methylphenidate. And if they feel better, if they feel more focused, then probably they've got ADHD, because the effect of the drug is different according to the person. So for example, if you give me methamphetamine, my response would be very different to somebody who doesn't have ADHD. I would probably appear sharper, more together at the right dose of methamphetamine, whereas a person without ADHD would appear overly hyped, overly talkative. It almost has the opposite effect. So stimulant drugs in people with ADHD will often have a calming effect at the right dose. Got to stress that, right dose. And with people who don't have ADHD, they'll often hype them. So there's this misnomer amongst a lot of students in that oh, I'm going to benefit by taking methylphenidate before my exams. The problem is you need sleep to imprint memories, and also it's probably going to decrease rather than increase your focus, and probably make you a little bit more paranoid about your exam. And these kind of facts and the factual way of messaging it to people is important, because that way they can make intelligent decisions around whether or not to even start the drug, which hopefully they wouldn't in that particular case. Does that answer your question? I know you asked about the screening. Unfortunately,
it does to some degree, but also, is there any type of research that has been done into, when we send patients for the 72-hour observation, when they're showing this, what is it that they're being observed for?
Okay, so that is usually when somebody's psychotic, and I'm glad you brought that up, because it raises a very interesting thing. So in my original setting where I was working in Lavender Hill in Cape Town, we had a lot of people who were floridly psychotic. And when you look at their lived circumstances, you often can understand why. Now, there's a growing school of thought that psychosis is a normal adaptive way of protecting oneself against environmental issues. And some of the evidence for that is, for example, in an intervention called open dialogue, which they've done in Nordic countries, and they're busy expanding it. It really works really well. Is when a person has their first psychotic episode, you have a team that works with the family for the next 24 to 48 hours, and all they do is talk. And in the majority of cases, there's no need for further medication. There's no need for further hospitalization. There's no need for the person to stop working, and symptoms usually don't get progressively worse. Now, we don't have that kind of resources in South Africa, but what I was seeing with people in my setting was if they weren't sleeping from the methamphetamine, for example, and they were in a very noisy environment, which most of them were, and there was a lot of paranoia around gang activity and that kind of thing, they would often end up in a state that appeared to be pretty psychotic. So they would go in for the 72-hour observation. Then they would come out. And if you didn't manage that afterwards, every time they had stresses, they would end up going in for 72-hour observation. And it was almost like, although they weren't consciously doing it, it was almost like they were learning that they can get some sense of relief, some time off the drug, some time out of this noisy, busy environment by appearing to be psychotic. And so it almost became a learned behavior. Now, in the 72 hours, what they're really looking for is signs of prolonged psychosis, delusional thinking, fixed delusions. They're looking for signs of the clustering of symptoms, which we term schizophrenia, which is sort of basically about 107 symptoms that they look for that are attained. And they're looking for, if it's drug-induced psychosis, is it going to resolve? They're not looking for ADHD. You can't judge whether somebody's got ADHD within 72 hours. And it's mainly for the individual's protection or for the protection of the people that they're living with, or the general public, because if you've got somebody who's floridly psychotic with paranoid psychosis, you don't want them walking around the street, because that is the one mental health issue which can be quite dangerous. I think in what was his name? The guy who wrote the book on psychopharmacology, Stephen Stahl, when he was lecturing in South Africa, he was saying that in California, they had between 5 and 7 clinicians killed every single year, which I find a phenomenal figure, because of people with paranoid delusions and on a regular basis. And so that's what they're really observing for, those kind of behaviors that indicate that there's something more permanent or problematic, or giving the person the opportunity to resolve it and not harm themselves in it. So that's what they're looking for. They're not looking for ADHD.
Thank you for that. Thank you.
Okay. Are there any other questions from people? What I would go ahead.
I don't know if you can see it, but she says for 72 hours involuntary admission, you have been deemed a danger to yourself or others.
Correct. So there's a form you have to fill in for it, and it needs to be filled in by family members, social worker, and then there's an evaluation, and then they'll probably take them in. But yeah, there's a potential for abuse there as well on the system, but in general, it's mainly for the protection of yourself or others that they'll take you in to see how that develops. And especially with substance-induced psychosis, they want to see whether it resolves or not. And depending on the busyness and the hospital and who you've got on duty, you will find there's often quite a lot of discrepancy on whether they will accept somebody or not, depending on the symptoms that are there. Yeah, it is useful as well when you've got people who are just chaotic, so sometimes it's used even though there's not a direct threat, but it shouldn't be. Okay. All right. So the other thing I wanted to say is that when we have in the next session, we're going to talk specifically about methamphetamine, about things like potential adulterants in it, what it actually is, what effects you would see, because that's the emerging drug in Tshwane at the moment. Why it's the emerging drug as well, hint of that is it's about price and effectiveness. And then we'll also look around some of the science on that as well, and how best to control that. So if you've got questions on that, it might be useful to put them in beforehand. I'm hoping to have psychiatrist Dr. Billy Beattie with me during that session. If not him, then I will find somebody else to join me, so you don't have to listen to my voice the whole time. Yeah, any other questions?
There's an article on the News 24. Yes. And I'm reading, the work that the Center of Study of Violence and Reconciliation has done shows that these drugs, they're referring to DEC, has not only has caused far-reaching impact on addiction, but have also fueled a great interaction of violence, such as sexual violations, which includes rapes and other assaults in communities. So my question is this: when people at a personal level, anecdotal, they have experiences of this level of violence because of crystal meth and all of those things, how do we balance out evidence-based knowledge versus that? Without
that's a very good question. So in the Western Cape in particular, where most of my experience is, we've seen that gangs don't mind somebody being on meth, but they hate their members being on heroin, because the meth definitely keeps people more awake, more vigilant. It increases sexual drive as well. The problem I've got with that narrative is that what it can do is it can lower inhibitions to some degree. It can keep people more motivated, and it can motivate them to do things which they typically wouldn't do on a regular basis, but they still have the propensity to do those things. No drug in the world will make you into an absolute animal when you were not an animal before or had the potential to be an animal before. So you've got to be very careful about those narratives. It brings out things in people that perhaps they don't even like about themselves, but they were underlying. So again, we've got to be careful of that narrative, because it's not as if it doesn't cause those things. It's not a direct cause. It's often a circumstantial cause. And also, I don't think that the use of drugs is ever an excuse for that kind of behavior, for rape and violence. It should never be an excuse. I have sympathy for somebody who maybe is shoplifting in certain circumstances. I don't have much sympathy for if they're shoplifting for food and that kind of thing. I have no sympathy for somebody who goes and beats somebody up when they're high on crystal meth or whatever. So again, it comes down to dose response and the way people believe that they have a right to behave on these things. We often see people who use alcohol, which lowers inhibition significantly, alcohol even more than crystal meth. in one of the studies that was done by Sweat, I believe, in Eastern Cape, people were saying, I drink in order to be able to rape, or I take meth in order to be able to commit the crime, or before I break into houses, I will take meth. And these are common narratives. And so what comes first, the meth or the crime or the violence? People, it's never just the drug. It's a context that we've got to look at. So I'm not saying that the drug's got nothing to do with it. I'm just saying we've got to look broader than the drug if we're going to solve the problem. Undoubtedly, there'd be less gangsterism if it wasn't for crystal meth in the Western Cape, but there would still be gangs. There might be different types of gangs and the way that we're thinking about it, but the phenomenology of gangsterism is driven by massive profits in the drug market. The violence that occurs is driven mainly by the profit incentive rather than the drug itself. And the drug can fuel that to some degree or make it easier for people to commit certain crimes.
Okay, thank you. Thank you, Sean, and thank you for everyone for being part of this session. We've came to the end of it. As Sean has said earlier on, we're going to have another session on the 6th of July. So please proceed by submitting your questions. You can even send it to me directly or here online, and we'll send the necessary links. Everyone, enjoy the rest of your day. Bye.
Thank you. Bye-bye.
Thank you.